you had forgotten to mention that, but now you are on top of things. Go figure. All right, I'm going to introduce our wonderful speaker tonight. If you don't know him, you will get to know him very well today. This is Dr. Eric Freitag. He's a licensed clinical psychologist and a board-certified neuropsychologist. He is the founder and executive director of the Mount Diablo Memory Center in Walnut Creek. Dr. Freitag's clinical practice includes the evaluation of dementia and other neurological disorders. He has an extensive experience providing medico-legal evaluations and consultation in the area of capacity and conservatorships, and has been designated as an expert in both Contra Costa and Alameda counties. I have used him in many of my cases as a 730 expert to get capacity declarations done. He has an extensive wealth of knowledge, and I am hoping he will bestow some of that knowledge on all of you fine folks today. So without further ado, Dr. Freitag, please take it away.
All righty, thanks, Doug. Let me pull up my screen here. All righty, so we were talking before we started the webinar that the last time I did a talk for CCCBA was about this time last year before all hell broke loose. So I'm sorry we can't all join together again. I've done a few of these Zoom webinars, and I also taught a class last semester. It's definitely a little different to do a presentation without a live audience. You lose some of that energy. And most importantly, I have no way of telling if my jokes land. So I can see Doug's face. So if I tell a joke, and I can get feedback from him to see if it was funny or not. So today's talk, I figure it'll probably take about an hour. It's a little hard to say because I revamped and reworked. It kind of merged together some different talks I've done over the years. So if you've seen me talk before, you've seen me present before, some of it will be some new stuff. And then I also updated some prior slides. So like I said, I figure it'll take about an hour, but if I feel like I'm running a little bit over time, I might have to maybe skip a couple of things, but definitely want to make sure I leave time for questions at the end. So let me get on here. Why is my slide not advancing? There we go. Okay, yeah, now we're cooking. Okay, disclosures. As mentioned earlier, I'm the owner, executive director of the Mount Diablo Memory Center. No other disclosures. So objective of today's talk. So one, we're going to review medical diagnosis of dementia. So when I was talking with Doug several weeks ago, and he invited me to come out and speak again, we were talking about, what are some things that I find and that he finds that, most of you guys as practicing attorneys would benefit from having increased knowledge with. And so this kind of formed the basis of establishing these objectives. And one is just getting a better understanding of the medical diagnosis of dementia, meaning what goes into, as a medical practitioner, what goes into formulating and establishing that diagnosis. Another thing that we'll spend some time talking about is understanding disease severity and its impact on capacity. A lot of it is pretty practical and I guess logical understanding, but we'll kind of review that, and I'll share with you some internal data analysis that I've done within my clinic that kind of illustrates that. And then we'll talk about identifying and supporting clients that you may be working with that have diminished capacity. What's the best way that you can support your clients and work with them? And then we'll spend a little bit of time talking about working and optimizing that medical expert relationship when you do refer and retain a medical expert in probate matters. And then hopefully at the end, we'll have some time to do a case report. All right, so what is dementia? Dementia is generally thought of to be an umbrella term for loss of memory and other thinking abilities severe enough to interfere with daily life. So another way that I've explained it is it's like saying somebody has cancer, right? As a metaphor, that it doesn't really tell you what specific type of cancer somebody has, and very similar to when you say somebody has dementia. It doesn't say what specifically the diagnosis they have. It's just a very much an umbrella general term. And then under that umbrella is you have different etiologies or causes of dementia. So Alzheimer's is by far the most common type of dementia, encapsulating 60 to 80% of all dementias. And then under Alzheimer's, let me actually bring up, there we go. Under Alzheimer's, you have different other causes of dementia, like Lewy body, vascular dementia, frontal dementia, and then other types of dementia conditions like Parkinson's, Huntington's, et cetera. And then encapsulating all of those is you can have, and in fact, it's quite common that you will have a mixed dementia, meaning that it's a couple of different pathologies affecting the patient. And I know I find clinically that, especially with older patients, a mixed dementia profile is quite common, and you can oftentimes see an Alzheimer's and Lewy body, or even more common, vascular dementia and Alzheimer's presentation. So there are actually over 70 different types of dementia-specific etiologies, and each disease has a differing course and prognosis, which really speaks to the necessity of trying to pinpoint as best you can a specific diagnosis and cause, because that will have pretty big implications as far as treatment is concerned. As I mentioned, Alzheimer's disease is by far the most common, 50 to 70%, or maybe even a little bit higher of all cases. By age 65, you'll have a greater than 13% chance of becoming afflicted with a certain type of dementia. And there's roughly a 2% increase per year of life. So by age 85, you have greater than 30. Some research has shown even as high as 50% chance of developing some type of dementia condition. Now, when we think about diagnoses, it's really, it's not that simple. There's a lot that goes into a diagnosis, and sometimes it can be impacted by other conditions that can mimic a dementia condition. So within, there's different frameworks of which you can diagnose dementia. So the DSM-5, the Diagnostic and Statistics Manual, of which we've, which you probably have all heard of, that's one of the main diagnostic manuals that is used in psychiatry and in medicine. And they diagnose what's called or termed major neurocognitive disorder. And what a major neurocognitive disorder is evidence of significant cognitive decline from a previous level of performance in one or more cognitive domains: learning and memory, language, executive functions, attention, perceptual motor, social cognition. And these cognitive deficits must interfere with independence of everyday activities. Now, this first point here, this can be pretty objective. Like, we have ways as neuropsychologists that we measure for this. This here is pretty subjective. So for example, I had a few years ago a referral of a patient, and in the clinical notes I was reading from the doctor said, well, you know, the patient has some cognitive issues, but it doesn't seem like it's dementia because it's not having too much of an impact on their day-to-day functioning. Well, and I evaluated the patient, and patient was quite impaired. There was pretty profound deficits in memory and language, a fair amount of executive functioning difficulties and confusion. And the reason why the doctor felt that it didn't have too much of an effect on his everyday activities, because his everyday activities basically constituted waking up, watching television all day, maybe microwaving a hot dog. And that was about the extent of his activities. He lived alone, was very isolated. And so it would take a much higher level of impairment to affect his everyday activities, because his everyday activities were so pared down because of his cognitive deficiencies. And so that's just an example of some of the subjectivity that goes into a dementia diagnosis that at times cannot, make it not so simple of a diagnosis. And then the deficits do not occur exclusively in the context of delirium, meaning that it's not due to some sort of acute changes in mental status, such as a recent hospitalization, surgery, or illness. And this is also another kind of convoluting variable or confounding variable, in that oftentimes patients can be diagnosed with dementia usually inappropriately in the course of a hospitalization, or right after being released from a hospital from some sort of illness or surgery or some sort of other medical event. And really what they're experiencing is that delirium, or a resolution of the acute mental status changes that is caused by the medical incident. And the final condition in the DSM-5 is that the deficits are not better explained by another mental disorder, such as schizophrenia, bipolar, or other type of psychiatric disorder. So this term in the DSM-5, the major neurocognitive disorder, that was a change. The DSM-4, the prior publication, was the term dementia was in the nomenclature or nosology for that publication. In 2013, the DSM-5 was published, and they removed the term dementia as it was deemed too stigmatizing. And so they instead labeled it this major neurocognitive disorder. And it was a bit of a controversial change. And part of the controversy is that it felt that it overly complicated and confused decades of previously established diagnostic nosology, and that people know what dementia is. It's been a term that's been used for generations, and all of a sudden to make this major change has caused a fair amount of confusion. And I've seen it clinically where I've had patients and or family say, well, he doesn't have, the doctor says he has major neurocognitive disorder, so thank God it's not dementia. And so then we have to do a fair amount of education with these patients and family to help them better understand the current status or condition of the patient. Medical professionals I have found, so physicians have largely continued to use ICD terminology, which is dementia, and then the different causes of dementia, Alzheimer's, vascular dementia, et cetera, that follow under that. Whereas psychologists and neuropsychologists are generally mixed. Some continue to utilize the ICD terminology and diagnostic criterias, and others use the DSM-5. It's neither right or wrong. You can use both. I prefer to continue to use ICD-10 diagnostic terminology, but just so you know, as individuals that work with medical professionals, you may come across different diagnostic terminology based on what sort of criteria or publication it is that they're using. And just so you're aware, I'm not going to read this whole thing, but the ICD-10 is the current diagnostic terminology for the under the World Health Organization, and they maintain that dementia diagnoses. And this long paragraph here basically describes or reflects what's covered in the DSM. And I do want to add a quick point. There's also within, I'm going to go back one slide. Within the DSM, there's another condition under the major neurocognitive disorder called minor neurocognitive disorder. And that is less severe cognitive dysfunction and functional deficits than the major neurocognitive disorder. So someone with a minor neurocognitive disorder may be experiencing a condition, what's called mild cognitive impairment, or MCI. And I'll talk a little bit about MCI later, but MCI is, if you think about how your brain works on a continuum, and if you have normal age-related functioning on one end of the continuum, and then you have very severe brain dysfunction on the other end of the continuum that we associate with dementia, MCI, or mild cognitive impairment, kind of falls in between that range, where it's not just normal age-related changes, which are always quite variable, but it's not to the severity level of dementia. So what goes into a dementia diagnosis may differ quite a bit based on the type of provider that's making the diagnoses. So for example, most patients are their first point of contact is going to be with their primary care doctor. And that's all they may be able to see, either because there's not other specialists available in the area, or the primary care doctor may not refer out for more specialty evaluations. So that diagnosis may come as a direct result of a primary care or family practice visit. And that will usually consist of a patient and family interview, a medical evaluation, evaluation of their heart and lungs and, typical things that a family practice provider would do. A practitioner may order labs, they may order medical imaging, and they may complete a cognitive screening evaluation. And typically, the total visit time may last between 15 to 30 minutes. Oftentimes, this is pretty suboptimal as far as diagnostic sensitivity is concerned for dementia. And it's more preferred that then after that primary care visit, the patient's referred out for a more extensive evaluation. But like I said, sometimes that's not always possible. And this is what the doctor has to work with in order to come up with those diagnostic findings that are consistent with the ICD. But oftentimes a patient can then be referred out to a neurologist. And this evaluation is similar, but more extensive than what a primary care evaluation might provide. But very similar, there'll be a patient and family interview. There'll be a more thorough neurological evaluation in addition to the medical evaluation. Most likely, a more comprehensive laboratory panel will be ordered. So this is going to be different than what your normal, annual visit where you're looking at your cholesterol and your blood sugars. This is going to be a more comprehensive lab panel that will look at other potential physiological markers that could rule out or contribute to cognitive decline. It's also probable that a neurologist will do a cognitive screening test and will order brain imaging. And usually these visits are longer, 30 to 60 minutes compared to a primary care visit. And this does offer greater diagnostic sensitivity for your typical dementia workup. And then this would typically where a neuropsychologist would come in, where usually after a primary care visit or a neurology visit. Then they'll be referred for a neuropsychological evaluation to truly look at how the brain functions in relation and in conjunction with their overall medical picture. And so similar to what a primary care would do and a neurologist would do, a neuropsychologist would conduct a patient and family interview, but this is oftentimes much more extensive. Whereas a total visit time for a neurologist may be 30 to 60 minutes. That's about 60 minutes is about as long as I'll do a patient and family interview. And during those interviews is where I'm trying to really gain a clear understanding of the causes and conditions and experience that that patient may be having, especially as it relates to cognitive decline and how it's impacting their day-to-day functioning. Thorough review of medical history, medical imaging is reviewed. The patient will complete a comprehensive neuropsychological evaluation. And the total visit time is anywhere between 1 to 6 hours. And really research has shown that this, in conjunction with a thorough medical evaluation, that a neuropsychological evaluation will offer the greatest level of a diagnostic sensitivity in a dementia workup. So when we look at the clinical diagnosis of dementia, there's 3 levels of diagnostic certainty, if you will. The first level is what we would call a possible diagnosis. And I was kind of thinking about this the other day, and I think a useful metaphor, if we were to put this in legal terms, would be a possible diagnosis would to me equate to a preponderance of the evidence, right? It's more likely than not that the clinical history is consistent with symptoms and history of dementia. So again, this isn't a legal conclusion or definition I'm using. I'm just drawing as a metaphor. And then the next level of a diagnostic certainty is what we call probable diagnoses. And again, if I'm continuing with the a legal metaphor, it would be maybe clear and convincing evidence, meaning that there's additional objective clinical evidence in addition to the history and symptoms. We have neuropsychological testing, brain scans, lab data that all point to a higher level of diagnostic certainty of a dementia diagnosis. And then the final level is what's called what we would consider definitive diagnosis. And those are obviously very rare because you're obtaining those on biopsy or autopsy. So most of the medical world is functioning under probable and possible diagnoses. All right. So you heard me on those prior slides talk a great deal about cognitive screenings, meaning what is being utilized in these primary care neurology visits and sometimes neuropsychological visits to screen for any sort of cognitive issues. And so if any of you guys have reviewed medical records, I'm sure you've come across different cognitive screenings that have been used. And so some of the more common ones are the Montreal Cognitive Assessment, which is this right here, the St. Louis University Mental Status Exam, the Mini Mental Status Exam, are probably the 3 most common cognitive screening tests that are used. And these are paper and pencil type tests, but there are some computer-based tests that are used in some doctors' offices now as well. So for example, a common one is the MOCA, excuse me, and it takes about 10 minutes to administer. It's out of 30 possible points with 26 or more considered to, or excuse me, 26 or less is considered to be abnormal. And so less than 26 is considered to be abnormal. And then you have 0 to 10 score would be severe to moderate dysfunction, 11 to 20 would be moderate to mild dysfunction, and 20 to 25 would be considered a mild level of dysfunction. I don't want to get political, but some of you guys may remember this quote from our prior commander-in-chief, person, woman, man, camera, TV. This was a description of the words that our prior president had to remember based on his taking of the MOCA test. And so if you may remember that interview, that was what he was describing. These aren't the words at all. These were just the words that he could actually see in the field of view during his TV interview. But that's how he was describing the words that he had to remember as a part of taking this test. So cognitive screenings, they're quite limited in what we're able to determine from these tests. Because they're so brief, they just give us a very superficial understanding of basic cognitive functions. They're not tests of mental acuity or intelligence. They're just meant to briefly evaluate basic cognitive functions. And overall, they're designed to be, I guess, somewhat easy in that if you are you have a typically functioning brain, you should and will score above the cutoff. Passing the test does not necessarily, though, mean normal, because it's very insensitive, especially for mild stages of cognitive impairment. And you also have a fair amount of high false negatives, especially for individuals with higher levels of education and intelligence. So, we spend time talking about what goes into a medical diagnosis of dementia, what sort of practitioners and what are the steps involved. And then I'm going to spend kind of the next part of this talk talking about the intersection of when dementia or other sort of neurocognitive conditions intersect with the legal arena in dealing with legal capacity, and specifically how disease severity will correlate with diminished capacity. So we all know that a diagnosis of dementia does not render an individual as incapacitated. In fact, it says that in the probate code. But what about other non-dementia neuropsychological conditions? So for example, individuals with MCI, just because they don't have the dementia diagnosis does not necessarily mean, though, that they also can't lack capacity in some legal way, especially as we're dealing with more complex levels of capacity, like contractual levels of capacity. And so it goes without reason that as you have the neuropsychological impairment continuum, you also have, as an increase in severity, you have a decrease in capacity. So that's pretty logical and reasonable. So when we think about measuring severity of cognitive impairment, one useful way to look at that is through the MOCA test that we just talked about. And I think this would be a good way to kind of illustrate that concept. So what I did is, this is not a published study. This is just my own internal quantitative analysis. This is observational. Again, this is unpublished clinical review. And what I did is I went through some records, medical legal records from 2018 through 2020. And among those records, testamentary capacity, so a pretty low threshold for functioning. The testamentary capacity was a referral question. And I selected cases where a MOCA was given. So I don't give a MOCA in every evaluation that I do. It just kind of depends on the specifics of the referral question. And among that review, I found 10 total cases. So among those 10, 6 of those cases, the results of the evaluation found that the patient met or would have met the diagnostic criteria for dementia. And among those cases, 4 were found to have testamentary capacity based on my reasonable medical opinion, and 2 were found not to have testamentary capacity. 4 of the cases had MCI, so that mild cognitive impairment. So again, that mild cognitive impairment, it's not to the severity level of dementia, but there's sufficient level of cognitive deficits that their neuropsychological profile is below expectations for just typical or healthy age-related brain functioning. And so 4 of those patients, are 4 individuals in that chart review had MCI, and 3 had testamentary capacity, and 1 did not. So if we break that down into MOCA severity scores, on a score of 0 to 10, 2 of the charts, 2 clients had scores 0 to 10. So that's pretty severe level of dysfunction. I mean, if you score 0 to 10 on the MOCA, that's definitely well within the moderate to severe range of cognitive dysfunction. There's a typo here. This should be a 2 right here. 2 individuals from those 2 individuals were found not to have testamentary capacity. So I apologize for the typo. Then the next level up is we had MOCA score of 11 to 15. And so obviously that's better than a 0 to 10, but 11 to 15 is still a score that suggests to me pretty significant cognitive dysfunction, sufficiently within the moderate range of impairment. And we had 3 clients that scored at that level. 1 was actually found to have testamentary capacity, and 2 were found not to have testamentary capacity. And then we're progressing down the severity to less severe or more milder impairments. And we had 4 individuals with scores of 16 to 20 on the MOCA. And this was interesting. Of those 4, 2 were found to have testamentary capacity and 2 were not. And then finally, we had 2 individuals with a score of greater than 21 on the MOCA, and they were both found to be to have testamentary capacity. So I didn't want to go through each one of those cases, but I thought it would be instructive to maybe pull out a couple of those cases to see, why they performed the way that they did and how it had an impact on their testamentary capacity. So for example, on case 1, let me just get a drink of water. On case 1, I found probably the most interesting in that they had a score of 14 out of 30 on the MOCA, which suggests, again, that's kind of that mild or, well within the moderate range of cognitive impairment. And I did diagnose, or this client would have had a diagnosis of dementia, but yet my opinion was that they did have testamentary capacity. And part of the reason, for whatever reason, this individual still maintained enough mental functioning capacity to really be able to articulate, not only basic testamentary concepts, but they could clearly articulate specifics as it related to their beneficiaries, as well as their assets. And then most importantly, they had pretty good recall of their estate plan. The genesis of this referral was more for contractual level capacity issues, which I did not feel that they had contractual capacity, especially applying probate code 811 standard. But the attorney also requested, as a part of the evaluation, just to opine on testamentary capacity, even though it wasn't necessarily a pressing matter at the time. But they did have a good recall of what they had done in the past, and especially as it related to the potential beneficiaries and heirs of their estate. And then here we have an individual with a MOCA score of 18 out of 30. So that's definitely better than the 14 out of 30 and within that mild to moderate range, but yet they didn't have testamentary capacity. They've still met the diagnostic criteria for dementia. And with this individual, even though their MOCA score was better, so to speak, they had much more confusion on family relationships. The individual had 3 daughters, and he could remember who his daughters were, but had a lot of difficulties tracking like his son-in-laws, who went with who. That caused him a lot of confusion. He had a lot of confusion on tracking his grandchildren, and he would also sometimes confuse the grandchildren with the daughters, as a couple of the granddaughters were much older. He was able to articulate basic testamentary concepts. That was no problem, but very minimal understanding and recall of his assets, especially really significant gross underestimation of the totality of his estate, which I'm sure you find is quite common. I know I find it where the individuals lived in their house, it's paid off, they've lived there for 60 years, and they have no concept that this is a multi-million-dollar house. To them, it's still around $60,000 for what they paid for it in 1960. And so even though this score was considerably higher than here, it just goes to show that it affects different people differently in regards to capacity concepts. And then this one was also instructive and interesting, where we have a score of 20 out of 30. So, pretty mild level of impairment. And they didn't even meet diagnostic criteria for dementia. They met criteria for MCI. And this individual understood testamentary concepts. They understood who their beneficiaries were, had a really good grasp of their assets and the value. But the biggest concern with this individual is they had no recall of recent and significant estate changes. And so to me, that was the main issue in establishing the opinion that they did not have testamentary capacity. All right, so kind of trying to tie this all together, where we talked about the medical diagnosis and what goes into that. We talked about clients that you might be working with, where there's you maybe have medical records, or there are some concerns about their cognitive functioning and what their capacity is. And so we talked about cognitive functioning severity and how that might have an impact on capacity. And so kind of for this next step in the presentation, I want to spend some time talking about how you can now best support your clients who may have diminished capacity. And this is coming from my perspective as a neuropsychologist, utilizing how I work with these clients and or patients, and trying to provide some information that you might be able to utilize with your work, recognizing though that not everything that I do may not fit into your practice model. And so there might be some adaptation that would be necessary. So to me, the best way that you can identify and then support clients with diminished or capacity is, one, is just really emphasize client observations. So really observe the client's behavior from the very first contact. And that may not be you as the attorney. It may be your staff. And if there's ever any unusual or behaviors or concerns, have your staff document that information. Was the client confused when they were scheduling the appointment? Was there, who scheduled the appointment? Did they have any challenge with instructions about the appointment, such as paperwork or driving directions? You may have a client, you know, if you practice in Walnut Creek, for example, and a client's coming from Walnut Creek, but they called 4 times because they got lost and talked to your administrative or paralegal. To me, that would be quite significant that they were having trouble following the driving directions. But when they come to meet you, if you were never informed of that, you may not be kind of keyed in or clued in that there might be a capacity related issue in your work with this client. And then, so past the point of first contact, observe the client before the start of the appointment. And again, in my own practice, my staff is trained. They don't spy on the client as they're waiting in the waiting room, but they kind of have their ear open to kind of listen out and, you know, determine is there any confusion? Is the client keep asking, for example? This just happened last week where my office manager came in and she said, you know, client so-and-so, he asked his daughter like 5 different times what the date is. So right away that informs me like, okay, well, there's, you know, obviously some memory recall issues that are going on. I had a client a while back where in the waiting room, when talking with his wife, she would talk in a normal tone, but during the evaluation, I had to speak in very loudly because he kept saying he couldn't hear me. But I didn't, when I asked my office manager, you know, when he was talking with his wife, does she have to talk very loud? And she's like, no, not at all. And so that helped kind of clue me in that it wasn't necessarily hearing that was the problem, is more of his processing that was a challenge. So those are just a couple of examples of the importance of having, you know, your staff aware of any sort of difficulties or behaviors that they want to make sure they inform you about. This quote here on the bottom, when does the evaluation start? This question at the bottom. So this was a couple years ago, and this was a clinical referral, and the patient was there with his daughter. And as they came in and got checked in and stuff, my staff comes and says, well, the daughter would like to talk to you really quick. And I was like, okay. So I meet her on the hallway, and she says, my dad would like to know, when does the evaluation start? And I was like, well, that's kind of an odd, you know, I'm thinking to myself, that's kind of an odd question. I was like, well, what do you mean? And she's like, well, he wants to know when he needs to be like on his best, you know, be doing his best and be on. And I thought it was a really interesting question. And I can't remember exactly how I responded, but what I was thinking is that really the evaluation starts right here. At the first point of contact is when the evaluation starts, because that's when I'm starting to gather clinical information. So when you're meeting with your client face-to-face, what I do in a clinical interview is I like to hear from the patient first, without you know, any sort of interjections from other family members. And through questioning, I'm asking them basic demographic questions. I'm asking what the date is, if they can tell me the date, just asking family information, occupation, and it's kind of, it comes across in an interview type format, but it's also kind of open-ended conversational as well. And certainly this information is important, but I'm also trying to assess the patient's ability to recall that information. How good of an historian are they? And then only later will I then correlate that information with a family member or a loved one to help fill any holes. I'll also ask the patient, especially just conversationally, to discuss recent events. You know, just as far as I'll ask them about the news or different trips that they've been on. I was referred a capacity evaluation last year. So this is a medical legal of this woman. She was like in her late 80s. And we spent the first 10 minutes talking, and she's a huge 49ers fan, and they just played the Seahawks it was a Monday evaluation. And so it was a Sunday night nationally televised game. And for that first 10 minutes, she told me about practically every single significant play of the game and the score of the game. And I could have ended the evaluation right there. Like just her ability to be able to recall such specific information about a football game the night before was pretty significant level of recall. And as I suspected, the outcome of her evaluation showed that she was doing just fine. There was no capacity issues of concern. So if you determine that your client does maybe have some capacity, cognitive capacity, mental functioning concerns, how can you best support them? Well, one is, try to do as best you can, support clients with diminished vision and hearing. And I'm especially finding right now that this video conference using Zoom is really challenging for clients with diminished hearing. It's just so much harder to hear out of the computer speakers, and especially if you're doing visits to their, video visits to their home, you don't know what sort of quality speakers they have on their computer or laptop. I would recommend, if you don't, that you use a headset like I'm wearing now, because it does tend to really help provide clarity to your voice. Certainly consider enlarging forms if there are vision issues. And then within a meeting, there are products you can purchase if you're meeting face-to-face, and assuming we will be able to start meeting face-to-face again here soon, that they can actually amplify your voice, and the patient or client can wear a headset, and a microphone will pick up your voice. And that would especially be important if they don't have a hearing aid, for example. Consider the time of the visits, especially for older adult elderly patients. The time of day can have a significant effect, and it's different for everybody. Sometimes more seniors are on in the morning, and sometimes others are doing better in the afternoon. Consider home visits, and again, this is after the pandemic, but consider a home visit. This senior that's or any of us are oftentimes more comfortable in our home, and so we'll function a little bit better, we'll feel comfortable, less stressed, and that can definitely enhance capacity. And then also really think about and consider, is a client recovering from recent illness or surgery? If there are capacity related concerns, they're recently recovering from medical issue, and there's estate or probate changes that are being considered, it may be worth waiting, if that's possible, to allow the client to recover and get better. So as I kind of wrap up the talk, I want to speak to how can we optimize the medical expert partnership. And this was kind of born out of my discussion with Doug, as far as, gosh, when someone hires me or, hires a medical expert, what are things that I like to be able to utilize to maximize and make the partnership much more efficient. So one area that I frequently encounter is really just an understanding in terminology and an understanding in the roles. And so one of the frequent areas of confusion is kind of understanding the differentiation between the clinical and a forensic evaluation. Well, clinical evaluation is something that's medically necessary. So that's billable to insurance. Whereas a forensic, and it goes without, you'll know this, but a forensic evaluation answers a legal question to assist the attorney or trier of fact. The key difference, though, between the two, or I guess some of the key differences, is that a forensic evaluation is typically much more rigorous than just a standard clinical evaluation. So it involves a record review, especially in personal injury cases. It may involve symptom validity testing, and also the testing is much more extensive. Clinical evaluations were much more limited by insurance companies, especially managed care, on our billable time. And so we're not able to get into this level of detail on a clinical evaluation for one of the reasons, because it's not billable. We don't get paid for it. Now, a clinical evaluation may at times answer questions pertaining to a patient's capacity, especially if there are concerns about safety and welfare. However, and the key difference is that a legal issue or the issue of legal capacity cannot be the sole basis for a referral. So for example, I may get a referral for a patient from, a doctor, and I'll do the clinical evaluation and provide diagnosis like dementia, for example, and provide medical recommendations. And then later on, I'll get requested to do a capacity declaration form. And I'm able to do that. So even though I didn't do a legal evaluation, the outcome of my evaluation may allow me to provide an opinion that the individual would benefit from being conserved in order to protect their safety and welfare. And that's usually the case for especially higher levels of capacity like conservatorship or contractual type matters. Oftentimes from a general clinical evaluation, though, it's hard to answer lower levels of capacity, like say testamentary capacity, nor would it necessarily be appropriate to be asked that, because testamentary capacity is not a medically necessary question that would be answered in a clinical evaluation. So as I mentioned, legal capacity evaluation is not considered medically necessary, can't be billed. And one area that I know is a big pain in the rear for neuropsychologists and other medical practitioners, what are called backdoor legal evaluations, where the attorney tells the client to have their doctor get a referral for an evaluation, so then it can then be later used for legal purposes. Oftentimes those generally don't work out because of everything that I just mentioned, that really to answer a legal question, we need to do a legal evaluation because it's much more exhaustive and specific to the legal question at hand. So when making that expert referral, we want to define the referral question. What is the capacity in question? Clarify the legal standard as far as what probate code we want it to be evaluated under, what burden of proof it should be evaluated. I know I find it helpful to have a short referral letter. Doesn't have to be anything extensive, but just kind of with a summary narrative and documentation of all the requests and questions that are being requested of me to be able to provide the most thorough evaluation. And that's always helpful because, when I talk with the attorney, I try to take good notes and make sure I get it all written down, but we're all human and sometimes I may miss something. And if it's not written down and documented, then it's hard to refer back to. Other helpful records that are good, if they are available as a part of the referral, are petitions or responses, a court investigator report, medical records, depositions of loved ones. If it's a financial capacity related question for the referral, a general accounting of the client's assets and holdings is very helpful because this is a key part of my interview and evaluation with the client. If we want to know if they can manage their finances, I want to know what the client knows about their own financial resources and assets. If it's trust and estate plan related issues, then prior copies of estate plans, copies or summaries of proposed estate plan changes are very helpful as well for the same reasons. I'm going to ask the client about that and really to best document their capacity to show understanding and appreciation and a reasonable ability to explain their understanding of those things. As far as collateral information, for me personally, I generally will not interview other family members or loved ones. The reason being is that I view myself to be an independent, unbiased evaluator, and usually these collateral informants are not unbiased, and so they all have generally their own take and perspective on things that can not be very helpful. And I would say I never do it, but like I said, generally won't do it. I may interview impartial friends or family members, but again, it's oftentimes very hard to find impartial friend or family members that don't have their own perspective. I'm going to talk briefly about different types of experts, and the reason why I say briefly is because I'm sure you're all very aware of these differentiations, but it's good to review it. So in probate matters, the types of experts that you might refer to are neuropsychologists, so we've talked about, and I'll talk a little bit more about it. And then there's psychologists. So psychologist is a PhD or PsyD, or the two degrees. And I should also add an EDD, which is an educational doctorate. They can also be licensed as a psychologist. And the training and experience is in regarding non-medical mental health interventions, consultation and treatment. And in California, psychologists are not able to prescribe medications. And then other common referrals are psychiatrists. And as you're aware that they're all medical doctors, they can prescribe medications. And their training experience is related to medical aspects of psychiatric disorders. And then just going back to neuropsychologists, and really this maybe should be a slide for the very beginning of this talk, so you have a better understanding of what I do, but within the context of a medical expert referral, I thought it'd be helpful to go through this just briefly. So a neuropsychologist is a licensed psychologist with a doctorate, and they have specific expertise, training, and experience in understanding of brain-related disorders and their impact on behavior. This title is not regulated by a state licensing board, and that's important because basically if you have a doctorate in psychology and you're a psychologist, you can call yourself a neuropsychologist. There's no regulation within the state. There might be ethical concerns, but not according to the state. So for example, you can attend a weekend seminar in neuropsychology and come out of it and say you're a neuropsychologist. So it's very important, in my opinion, to look at the credentials and experience of any neuropsychologist that you're looking to hire as an expert. So what are those qualifications? Well, really at their most basic level is a pre-doctoral internship with an emphasis and rotation in neuropsychology, a 2-year postdoctoral fellowship in neuropsychology, membership in neuropsychology related societies and organizations, and demonstrated continuing education in the field. And then board certification. Now, board certification is not required to call yourself a neuropsychologist. And I know plenty of neuropsychologists who are not board certified, who are wonderful and excellent neuropsychologists. But a board certification could demonstrate more rigorous evaluation of credentials and experience. Neuropsychological evaluation, I kind of went through this earlier, but just briefly, it's a comprehensive interview, review of medical records, a full battery of comprehensive tests, but that may not be necessary for all capacity evaluations. The battery length can last anywhere from 1 to 10 hours, and it just varies by client's capacity, age, and medical status. The battery objectively evaluates all cognitive function domains. A legal capacity examination will differ based on the referral question. So for example, if it's around estate planning, financial, testamentary concepts, then questions will be directly specific to those contested issues. A specific assessment of decision-making and independent living will be given, especially if it's around conservatorship related issues, home safety, finances, basic reasoning and judgment. Here's a look at the different domains of functioning like attention and concentration and memory and learning, spatial functioning. So when to consider a medical legal evaluation? Well, if there's suspicion of cognitive impairment that raises concerns about a client's capacity, you want to produce a defensible work product. So, consider an ante-mortem evaluation. So for example, in cases where there's high family conflict, there's a significant change in their estate plan from previous decisions, or maybe based on these two, there's a high probability of future litigation, then it's my recommendation that doing an ante-mortem evaluation is highly advantageous. There's concerns for undue influence. And then this last part, when as a client, or excuse me, as an attorney, you may have genuine concerns for your client's current health or cognitive functioning. Especially, I know, a lot of attorneys have worked with their clients for years and years and years, and you get to know them, you get to know their family, and you can observe, some of these changes, and you have a genuine concern. And I get frequent referrals from attorneys saying, hey, there's nothing going on about, any capacity issues, no undue, I'm just concerned about my client. And if that's the case, even though it's coming from an attorney, so to speak, it certainly can be something that we will look to get billed through the client's insurance if it's truly due to a medical necessity. And how we would do that is then work with the client's doctor, get a proper referral, get the proper insurance verifications, and get the client evaluated. And then certainly consider a medical legal evaluation when post-mortem analysis of an individual's capacity at the time of making a decision is in question. All right, so let's finish this up with a couple of quick case reviews. So these aren't the client's real name. In fact, I use my grandparents' names, may they rest in peace. And this isn't the client's real picture. So I just thought it would add more interest to the slide to put that in there. So this first case, I include this case just because I think it's a good example of a partnership with an attorney that happened very quickly. The attorney called me and says, hey, I really need your help. Is there any way you can get in to see this client as soon as possible? I know exactly what the outcome is, but I just need to show the judge this evaluation so we can protect Marvel. And so I was able to get in and see Marvel like within 2 or 3 days. She was in a residential care facility, so I was able to head out there after hours and get the case done. And really, ultimately, the outcome was very favorable to best protect this nice lady. So, and you'll see why it was so important in just a second. All right, so this is a 93-year-old female. She had moderate dementia, and she was in assisted living. She had no immediate family, and she had a moderate estate. But her niece, who was local, had served as Marvel's power of attorney for several years and was just basically the one responsible for managing her care and well-being. The client's and the niece's attorney was notified by an out-of-town attorney of the nephew, so the niece's brother, of intent of the client to change power of attorney. So that was when Marvel was referred to me to evaluate her contractual capacity to designate an agent or a trustee. So the case is interesting in that the nephew really had no involvement with Marvel, but within the last year, he started visiting approximately 1 time every month to spend time with Marvel. At around that time, he also contacted his sister requesting money from her and then pressuring her, just saying, well, why can't you just take it out of Marvel's funds? No one's gonna know, it's just you and me. Through the course of the visits, he had convinced Marvel that she was receiving poor care and convinced her to move in with him and his wife. And how the niece knew about this is because he had Marvel call the niece while he was there, and she could hear her brother coaching Marvel over the phone, telling her that she wanted to move in with her brother. In fact, the nephew attempted to remove Marvel from the assisted living facility, but was fortunately blocked by staff. And shortly thereafter, the niece received notice from the attorney. So I came in, did a very brief neuropsychological and capacity assessment. I think it was what we call a bedside evaluation, where I think I gave the MOCA at the time, and maybe just a few brief kind of bedside memory type tasks. And she had moderate to severe cognitive deficits. She had difficulty identifying who her family members were. She knew who her niece was, but she could not really remember who her nephew was. She had no insight into self-care needs. For example, she would constantly try to rewear soiled underwear. And she certainly could not explain the purpose or consequence of a power of attorney. And so based on my evaluation, the attorney petitioned the court for conservatorship of a person in estate, and the judge assigned the niece as a conservator. And I think there might have been a restraining order that was provided as well. So again, this was just a good outcome. I think, the turnaround on the evaluation was just a few days, where the attorney can then petition for an emergency hearing, and it ultimately turned out for the better, that the Marvel's safety and welfare was looked after. All right, let me quickly do Ray, and then we'll have about 10 minutes for questions. All right, so Ray is a 78-year-old widower, retired financial services planning. In this case, I think is more interesting because it's a little bit more convoluted. It's not entirely clear as far as what was going on with Ray. He's upper middle class. He's living comfortable retirement, but he's not wealthy. He continues to live alone with support from his 2 daughters who live close by, and he's generally healthy. And he just takes a couple medications. So there's certain risk factors of Ray that are just noteworthy. He's living alone. He's a retired financial professional. In financial services. There are some vascular risk factors with hypertension, high cholesterol that could put him at risk for vascular cognitive issues. And he does have some financial assets. So Ray is, over the course of about a year, he's been victimized by several financial scams: the Jamaica lottery scam, the jail grandchild scam, sweepstakes scam. So basically, I think he fell for it once, and then he was targeted at that time. The daughters were really only alerted that there was an issue because a family friend witnessed a confrontation with Ray at the grocery store at the Western Union counter. Basically, Ray was trying to wire money to these individuals, and the Western Union person did not feel comfortable with that and was refusing to do that. And Ray was making quite a scene about not being able to wire the money. The daughters estimate, upon later review, that Ray had lost up to $90,000 and probably more from these scams. So Ray's behaviors. The daughters confronted him, and even though he wasn't convinced he was being scammed, he indicated he would stop sending money. He was trying to please his daughters, but he refused to allow his daughters access to his bank accounts. The daughters they weren't convinced, so they utilized tradecraft to gather further information. What they did, one daughter took Ray to lunch, and the other daughter broke into the home and went through Ray's bank book, checkbook, and also account statements, and determined that, yeah, he was still indeed giving away money. And then a neighbor was over visiting once, and a phone call came in, and he took it in the other room and was acting very hush-hush, and the friend and neighbor could actually overhear his interactions with one of the scammers. And it was at this point that local police were notified. So the daughters consulted the family attorney, and power of attorney for finance had previously been drafted. And the attorney met with Ray and basically said, well, we can do this, the easy way. You can agree to have your daughters help you out, or, we can get, the incapacity clause invoked, and then things can be taken over against your will. But he agreed to do an evaluation to prove he can make his own decisions. And so the referral was evaluate cognitive functioning, financial capacity, and invoking the incapacity clause. So why is his history of being a financial planner a risk factor? He's definitely in the target risk area, because individuals like Ray, the concern is that he still thinks he has a high level of financial wherewithal and knowledge to make these decisions, but his cognitive functioning has limited his cognitive impairments have affected his insight into making those decisions. So it's not the little old lady who never touched finances and her husband did it all. It's not necessarily her that's at risk. It's the individuals that feel they have the knowledge and skill set to do it, but have since lost those skills and now are at greater risk. During the interview, he could explain in theory why people thought he was being scammed, but really he thought he was doing the scamming. Like he thought he was really in some lottery scheme where he was going to get paid that, hundreds of thousands of dollars. The evaluation, interestingly enough, showed mild cognitive impairment, not dementia. He actually passed the financial capacity evaluation, except one, so basic financial literacy he could pass, which should be expected. He was a financial planner. But interestingly enough, he became very confused on a simulated credit card management activity. He just had no concept of being able to understand interest and which bill he should pay first. And that was a stark contrast, I suspect, considering his history as being a financial planner. So the question was, does he have capacity to continue to manage his affairs? In my opinion is that he did not have capacity to continue to manage his financial affairs. He was unable to reason logically. He was unable to act in his own best interest. So I wrote the report and gave it to the attorney. And the attorney basically was able to convince Ray to allow his daughters to serve as power of attorney for his finances. And then so immediate steps were then taken then to secure and change his bank accounts. So hopefully it was a positive outcome after that point. So in summary, I leave you with this quote. It says, I used to think that the brain was the most wonderful organ in my body. Then I realized who was telling me this. And so I leave you with that quote by Emo Phillips, a great comedian. Here is my contact information if you would like. And I'm happy to entertain questions, and I really appreciate your attention. And I hope some of my jokes landed, even though I couldn't hear you laugh.
Job well done. Go ahead, Samantha, and take away the Q&A.
So one of the first questions we have, Dr. Freitag, is what's the difference between a DO and an MD in terms of qualifications to assess capacity and conservatorship matters, if any? Does the court value the opinion of one over the other?
So I can answer just the very first part of the question, and then the latter legal aspects of the question, I have no idea. So an MD is a medical doctor. A DO is a doctor of osteopathy. They're both physicians. You can have both degrees and be a licensed physician. A doctor of osteopathy versus an MD is a little bit different training, but they still have the same requirements as far as medical school, residency, fellowships, etc. So my brother's a physician, he's an MD, and I asked him, I said, Gregory, what is a DO? And he's like, I really don't know. But that's basically he was being a little bit of facetious in that answer.
Got it. Next question we have is, what's the source of the terms possible and probable diagnoses? Is that also DSM-5?
The source, I don't know what exactly. I mean, I can't dial it back to source documentation, like who came up with that. That's just the kind of established clinical criteria. And within the DSM-5, boy, I'd have to re-review it. I don't review the DSM-5 that often just because I use the ICD, but the possible and probable diagnostic criteria are kind of well established in standards within the field. Research somewhat differs on it, but common understanding is that if you are providing a possible diagnosis, research has demonstrated around a 50 to 60% diagnostic certainty. Probable diagnosis, there's been as high as 80 to 90% in different studies with different neurodegenerative or dementia conditions, which is pretty consistent for medicine.
The next question we have is, in evaluating testamentary capacity, do you take into account the level of complexity of decisions involved, such as, for instance, a choice of beneficiary or fiduciary, like a trusted person, versus a choice concerning a complex tax avoidance provision? I ask because case law indicates that the courts are beginning to make this distinction.
Doug, will you object? That was a compound question.
I'll object.
So I'll kind of distill the question down. Do we evaluate the level of complexity? Well, yeah, absolutely. I mean, that's the legal standard. Are we looking at it under Probate Code 6100.5, which establishes testamentary capacity? And the way that question was formulated, it sounded like that was a much more complex type of decision-making processes. So I wouldn't view that under testamentary type framework. It sounds like to me under more of a contractual Probate Code 811 type of framework, of which we would want to evaluate for that higher level of understanding and cognitive processes necessary to make contractual level decisions.
Great. So our next question is, how do you conduct a post-mortem evaluation without a personal interview with the person? What can you do in addition to a simple medical record review?
So obviously the medical record review is very helpful and can be very influential. And then beyond that is just trying to develop sufficient level of documentation in order to formulate an opinion. So that can be review of petitions and responses, any sort of court investigator reports that may have been available prior to the individual passing away. Oftentimes review depositions from family members and try to tie together the narrative based on that. So it's not just one single thing, it's really an accumulation of the records. And oftentimes, I'll come back to the attorney and say, with the records that we have before us, I don't see that this meets the legal standard for the burden of proof to invalidate or say someone didn't have testamentary capacity or other types of capacity.
Sorry to interrupt. So I presume that if you don't have the court record or you don't have a court case that was happening, that you were just going to be able to rely on the medical records if the issue arose after the person passed?
Yeah, exactly. Well, if the person, the reason why I say if I review the petition, for example, is because in those records, it will provide the perspective of the petitioner. And so that's helpful information, not necessarily because it's very prejudicial. I mean, they obviously have their own take on things, but it helps me get an understanding of what the narrative is. And then I'll also review the responses to the petition, because that helps me give the other side an understanding what the narrative is. And then you try to look at objective evidence, so to speak, or objective information that you might get from medical records that then can help tie together those two narratives and then formulate what I would view to be my most reasonable opinion on the matter.
So kind of along those lines, how reliable are postmortem evaluations to determine testamentary capacity at time of signing a will or a trust? What factors impact reliability?
It just really depends on the nature and extent and validity of the records. So if you have very minimal medical records and minimal other little information that provides context and information, then you can't form any opinion based on it. So it just really depends on the quality and validity and detail of the records.
What is the difference between cognition and intelligence and acuity?
So cognition is it's how our brain functions. It's a construct of how our brain functions, how it thinks, how it remembers, how it processes information. That's cognition. Intelligence is oftentimes viewed to be our brain's ability to respond to and adapt to novel situations. And there's different types of intelligence. You have intelligence, what we call crystallized intelligence, and that's all our previously learned knowledge and information that we've gained over the years. And then you have fluid intelligence, which is your ability to respond to new information. And those two kind of merge together to basically form what our overall intellectual capacity is.
If someone has a high MOCA scale, but there is a finding that there is no testamentary capacity, doesn't that make it highly likely that there will be litigation about that issue?
I guess that all depends if there's reason for the issue to be litigated.
Yeah, I agree. Okay, that looks like, oh, one more question came in. What do you recommend attorneys do to document a client's testamentary capacity? Videotape the execution of documents, have client visit the PCP that day, seek a full battery of evaluation form from you? Sorry.
Yeah, so kind of referring back to a couple of those slides, if you have, as an attorney, you have reasonable concerns, like I said, about the client's capacity to make a estate planning decision, or you anticipate that this could be a rather contentious decision. There's high family conflict, there's significant departure in or changes in beneficiaries, then in my opinion, I think it's definitely worth it to spend the money and get an evaluation so that you as an attorney can then create a defensible work product, which I believe, and you guys correct me, but that's protected information, right? Under attorney-client privilege, correct?
Right.
Yeah. So that way you go into it as the attorney, knowing and understanding that your client can or maybe cannot make a decision that can potentially have drastic consequences down the line, especially after they pass away.
Yeah.
I have one question, Doctor.
Yeah.
Yeah, so on that same thread, if you are hired as an expert witness for one side in a litigious battle, what is your general approach, what you do? I mean, obviously it's case by case situation, but can you give us, kind of a basic overview of the steps you take when you are hired on one side as an expert, not as a 730 expert?
Right. And are you talking about like on a postmortem or antemortem, or it doesn't matter? Either one.
No, we'll just say a conservatorship, litigious one, and both sides have their own experts, let's just say.
Right. So my approach is whether I'm hired by the petitioner or I'm hired by the respondent, my approach really doesn't change in that my view is, and I know this is different among different experts, but my view is I take an impartial approach, and I take an approach to the referral questions and answer it as honestly as possible. And at the end of the day, where I feel like I can best serve the attorney is sometimes telling them, I got nothing that's going to be helpful for your client. Whether it's the client lacked testamentary capacity or has testamentary capacity or other types of capacity, I'll just try to make my most reasoned and impartial opinion based on the records and information I have before me. And sometimes that can be very favorable to a client's case, and sometimes it can be not so favorable, but I feel it's my duty to be able to provide that information to the attorney so they can best support their client.
Well, Dr. Freitag, we are over time, so you provided us with lots of great information. Thank you so much for your time tonight. We certainly appreciate it.
Thank you.
And we hope to see everybody